So what is Sjogren's syndrome, Doug?
Sjogren's syndrome is marked by dry eye, dry mouth, and autoimmune.
There you go.
I mean, that is what we have in that triad.
It's
And it really is this inflammation that occurs within the lacrimal gland that is going to really reduce the tear production in the salivary glands and the parotid glands that are really going to affect that. And the importance part about diagnosing properly, you say, well, what does it matter? I'm still going to treat this patient with maximum dry eye treatment. The whole point is to get the patient under rheumatology care and dental care, because the secondary Sjogren syndromes is what can kill people.
Yep.
So I think, prevalence of Sjogren's syndrome, as we see, approximately 4 million, 1 in 10 of these patients with dry eye have underlying Sjogren syndrome. So it really, there's this delay in diagnosing, and that's what's really tried to, because there's a lot of challenges in terms of the variable presentations, the evaluation and diagnostic techniques, and I think probably one of the biggest challenges is that the traditional SSA, SSB, the Roe and the Law test has really poor sensitivity and specificity and takes many years to actually be positive. And again, we talked about the ocular symptoms and the oral symptoms. We see that, and also when we see those patients, their corneas look uniquely different also in terms of their staining pattern with this whole patchy.
And you can hear it too when they're talking. There's a lot of, you get that dryness going on there. And your instantaneous thought should be, you hear dry mouth, you see dry eyes, you should be thinking Sjogren's.
And they bring a bottle of water into the exam room with them, or a little thermos, and then I'll always ask, can you eat a cracker without fluid or liquid? And a lot of patients say, no, I can't do that.
No.
And so that's, just some questions you can ask, the patient as we're looking at Sjogren's. Fluorescein, lissamine, I don't use lissamine. Not only is it impossible to get, but I've really relied on fluorescein with a Ratten 15 filter.
100%.
Is what we've really gone to.
And you need to give it enough time. And I mean, look at your eye, Doug. That's hideous. Oh, it's courtesy of. I thought it was your eye. Yeah. But yeah, that splotchy pattern you talked about. I mean, it's patchy, really apparent right there.
That would be your.
But I don't think we do staining properly.
No.
People will put it in, and it's just that instant. You got to give it. You got to let it ferment. You got to let it settle a little bit.
Yeah, and I this 2 minutes. That's a great. Put it in.
Is a good bunch.
Start doing other things, then come back and look at it again.
Right.
And you'll see so much more staining. And the other thing, it gives a chance to clear. Kick up the magnification, and then you can see micropunctate. Now, that doesn't necessarily apply to Sjogren's, but it applies to your regular dry eye patients, is looking at that small amount of staining that we have. So this Sjogren's diagnostic test that we have when we're looking and doing SSA, SSB, ANA, rheumatoid factors, looking at these, what we really need to do and what we have now is a test that is very specific for early detection markers. And I think that's the really the most important aspect. And that's what I do. It's called the SHOW test. But when you write it, you have to say early detection Sjogren's. Otherwise, they will just do SSA, SSB. Because the lab, they can do the RA factor. They can do the other components of that. But then they have to send the blood out to one lab in the country to get the early detection. But I find this really invaluable, and I don't think there is a week that goes by that I don't send these tests off.
It's good stuff. I mean, think about the long-term impact on identifying it, right? What is it?
And
19 times increased risk?
Looking at 19 times increased risk of non-Hodgkin's lymphoma if a patient
You're
has
saving
Sjogren's.
lives, goddammit.
Yeah.
I'm sorry I had to go there, people, but you are, okay? Look at that, 1.54 more deaths per 1,000. When people say you're an optometrist, you say, I save lives, okay?
Yeah, we need to tell that to a friend of ours.
Oh, that is true, yes.
So that's the importance of getting this diagnosis to get the patient in the proper care from both dental and rheumatology so they can be monitored on an ongoing basis. And I think that really is the impact with that. And the complications from that, from a corneal standpoint, is right through to filamentary keratitis, corneal perforations. I mean, it can really cascade, and that's why you may not. And this is that case where you may not see the patient improve a whole lot, but if they can stay steady and they can stay stagnant on that, again, you're saving vision at that point.
Saving vision.
Yep.
I like the fact that Cernenergem is actually, currently, it's not approved for Sjogren's, but then their phase 3 multi-center clinical trials that are going underway, they're looking at some endpoints. I think that sounds like a really, really great application for neural growth factor for that.
No,
for
absolutely. And it all ties together. And those are some of the first patients I also use that on, because you test your Sjogren's patient, their nerve corneal sensitivity is way down.
Yeah. Yeah.
And then we talk about the the PCP, the dentist, the rheumatologist, and then us as the eye care provider, continuing to manage those patients. And we're rounding things out.
0.05% cyclosporin was my bread and butter, my friend. It was the first medication approved. We know cyclosporin works. It inhibits T cell activation. I think for some of us, we felt it didn't work fast enough. For some of us, we felt that the challenge was keeping patients on it. We saw increase in Schirmer scores, reducing corneal staining, increased GABA cell density. It comes in a multi-dose bottle. My challenge with 0.05% cyclosporin is we talked about before about generic versus branded. And the challenge here is that in this generic market, there's so many different variabilities.
And that's really concerning, because there's this big push, and you don't know whether it's going to be generic and still made by Allergan and in an emulsion.
AbbVie, Doug, get it?
AbbVie, yeah.
Yes, we've buried Allergan.
Oh, that's right. We did that several times today.
Yes.
Or we don't know if it's in the vehicle is just saline solution. We just don't have any idea. And as we talked about earlier, the method of delivery is and that's my biggest concern about
100%.
generic 0.05 cyclosporin.
Well, a lot of these immunomodulating agents don't like water.
They don't.
Cyclosporin hate water. Water hater. It's like a cat. Meow. Does not like water. I mean, I'm assuming. I don't know much about cats, but but we have higher concentrations of cyclosporin, right? Like 0.09%?
Yep, we do.
Do we? Yeah. Nope. No,
Well, and this,
we have lifitegrast too.
0.05 cyclosporin was approved in 2003, and we didn't see this drug, the lifitegrast, until 2016. I mean, so 13 years, and we had one drug, we had off-label steroid use, punctal plugs,
Right.
and lubricating drops.
Right, which is why I think people just went artificial tears.
Yeah.
It was literally, at that time, it was like a Bob Marley documentary, One Love.
Yeah.
You just said one love, one love. So lifitegrast is different, right? It inhibits T cells.
It is. It inhibits T cells. It still is under the category of immunomodulator, and it improved both signs and symptoms at 12 weeks with improvement as early as 2 weeks. And I think that's a really important thing, because we were waiting quite a while and trying to encourage and pulling patients along to actually stay on the 0.05% cyclosporin. And I think that was a challenge for many, because how many times you get a referral or you get a new patient and they said, oh, I already tried that. I tried cyclosporin and it didn't work. And you say, how long were you on it? Well, I had 5 vials that they gave me in a trial.
Right.
Or that they were on it for a couple of weeks. And so, to get that, and when this was released, it was like, wow, this is going to help, our patients pull us along instead of us pulling them along if we can show them some symptomatic relief. So I think this was an important part of the progression that we were having. And I think that, their clinical trials again showed that in 2 weeks, half of the trial showed symptomatic relief.
Right.
And this also was the first drug approved for both signs and symptoms.
Yeah. And I think, the nice thing about this is that it works in a different, it's a different ICAM inhibitor. I mean, it's not the same as cyclosporin. So it's a unique opportunity to kind of help reduce the production of those T cells.
And Mark, I still find that combining cyclosporin and lifitegrast has a synergistic effect. So now let's go to 0.09%. And again, we're talking about methods of delivery.
Right.
And mechanism of delivery. And this 0.09 cyclosporin, you say, well, okay, it's almost twice the concentration. But the impressive part of this is the nanomolecular formulation, because you mentioned cyclosporin hates water. Okay, it is repelled. So what you do is you take this hydrophobic molecule and you surround it with a nanomicelle that is hydrophilic.
Yeah.
And it'll draw through the tissue. And what it showed was about 3 times the concentration to the target tissue.
Yeah.
To me, that's impressive. And that's why we're seeing same molecules, different method of delivery.
And also, I think just at the academy, they were able to demonstrate that switching patients from 0.05% to 0.09%, patients actually had increased visual acuity, increased Schirmer scores, tolerability was better. So to that same vein, I'm actively looking to put patients on branded. and using that N-cell technology, which is what the nanomicellar.
And Mark, you went over that just kind of quickly, but when we talked about increase in visual acuity and I think that was 60 days, wasn't it?
Yeah.
Increase in visual acuity, I mean,
happy.
that's dry eye.
Yeah.
That's the whole problem, is it's going to affect individuals' visual acuity.
Yeah. So 0.1% cyclosporin.
Let's go to that. Let's talk about that.
This is a brand new medication that was literally just came to market.
This was a breaking news story on our last show.
It was, yeah, and now it's here.
Now it's commercialized.
Yeah. This is the first water-free molecule, the first water-free cyclosporin that is available on the market. FDA approved in June of 2023, marketed in January in Hawaii, coming out here, indicated for the signs and symptoms. What's crazy about this is that this is cyclosporin 0.1%, but it's in the novel vehicle is basically perfluoral butyl pentane. And that may sound familiar because our next slide is something called perfluoral hexyloctane. And for those of you that know, you know, okay? But perfluoral butyl pentane is the same type of molecule that holds the cyclosporin.
And it's so interesting when you consider perfluoral hexyloctane and how it feels so oily that this would actually blend in with cyclosporin. So I don't know how they did that. And this is Horizon Pharmaceuticals, and I think they just launched this last week. Right? Harrow. That's Horizon is the Tapizio.
Tapizio, yeah. But it's what's nice is the spreadability of it. It increases oxygen content, and their phase 3 trials were pretty significant. It was pretty impressive.
Yeah, they were very quick. So, and that was the Gobi and the Mojave on the perfluoral hexyloctane. You know, looking at the sister, because it was same company that actually developed
so
it.
Novaleak developed this molecule, which is, again, people, I think you need to understand something. There's no preservatives in these. This is a water-free, so you don't have to preserve anything. You get what you get. I mean, this is it. So for Harrow with the Vevi, you have cyclosporin combined with the perfluoral butyl pentane. Here, you have perfluoral hexyloctane, otherwise marketed as MIBO. And it's spelled M to the I to the E, not the M to the E to the I. And for those of you who haven't used this yet, I mean, it's a unique opportunity to help stabilize the evaporative effects of the tears. I mean, it's literally saran wrap on top of your Rice Krispie treats. It doesn't harden out. You don't just say, who didn't put the saran wrap back? It keeps the tear quality on there longer. And you know, we saw 4 times daily for 57 days, 2 times improvement in corneal staining, 4 times improvement in central corneal staining, and 1.5 times improvement versus control in the eye dryness score. So this is a really just silky smooth way of kind of stabilizing the tear film.
You know, to that point, what I tell patients to really distill it down is anytime evaporation on your eye exceeds your supply, you have dry eye. Yeah. And this is putting a nice little monolayer, a biodome, if you will, over the top of the tear. Yeah. Because it doesn't mix with the tear, it goes over the top of the tear.
So you don't like saran wrap on top of your Rice Krispie treats? You like the biodome?
I may start using that.
Yeah.
I may start using that.
All right,
but,
you know, I'm going to start using, you don't want to get high on your own supply. No, I don't see how I can work that in there. So yeah. Yeah, I mean, MIBO, perfluoral hexyloctane, unique, waterless. The one thing I also like to tell patients, these are semi-fluorinated alkanes. So you have basically 8 oxygenated carbons, and then you have the fluorine. And so literally the fluorine loves the air, whereas the non-fluorinated love to be in the watery, oily portion. So it just creates this polarity across the top of the eye. And it just makes me sound smart when I say that.
It does.
So thank you.
Thank you. Let's talk about, we talked about this last time, but let's talk about this as a method of, and why is this in dry eye, Mark?
I don't know why this is in dry eye, because basically, as we talked about before, right, they have their clinical trials for the treatment of meibomian gland dysfunction. That's right.
And all of us that started using this right away were going, hey, my dry eye patient. I mean, and I think that what's so amazing is patients have less awareness of their eyes when you treat the mites. They have less awareness.
So what's interesting is that, you know, when patients get prescribed Xdemvy, and it's a 6-week course, but it's an overfilled bottle. And so what I started doing, Doug, is that for my MGD patients who also have Demodex, is I tell them, I want you to finish the bottle out.
I do the same thing.
Because in this clinical study here, they were doing these phase 3 clinical trials, they were doing it for 12 weeks. Because as Doug, you mentioned before, the brevis are deeper, harder to get to, so you keep it in the Lotte-Lanner, okay, in there longer, and we're seeing some cholera cure, the lid margin erythema cure, as well as improvement in the secretion of the meibomian glands. This is an
The other thing I'm
ongoing
doing a
thing.
little bit different on now than when I first is, I'll make sure patients wash their hands, and then I'll have them put a drop in their eye, squeeze their eye. The excess that comes out, I have them rub it into the upper and lower lashes also. And actually, then I'll have them go down on the cheek as well.
I just don't trust my patients to stick their fingers in their eyes. I don't know. I'm just not, hey, put that in your eye. It's like, oh, okay. Have you ever looked at some of your patients' fingers? Oof.
Well, that's why I
Janet
say
Jackson, you
wash
nasty.
them before.
You
So,
nasty.
but it really it's really changing things, because I think the early results that we saw, and we saw more meibomian glands yielding secretions, we saw the patient really kind of exponentially improving with some of their dry eye symptoms. So it's going to be very interesting as that phase 3 rolls out. What happens with
It
that?
definitely will be. So